Our speaker tonight is Greg DCD. He's an area clinical manager for specialty care for about the last 7 years, based mainly out of Banner University Medical Center in Phoenix, Arizona. He's a graduate of Midwestern University. He's on the AMSAC Convention Planning Committee, and in fact, he was a presenter at this year's AMSAC meeting on this very topic. So without further ado, I introduce to you Greg DCD.
Thanks, Jeff. Something switched over here. All right, so good afternoon, everybody, from the surface of the sun in Phoenix, Arizona, where we are continuing to break records for the most consecutive days over 100 degrees. Yay for us. Just more reason to stay inside the icy confines of the operating room and perform NRP, transplants, and total artificial hearts. Like Jeff stated, I am the area clinical manager for specialty care, overseeing our teams in Flagstaff, Prescott, Phoenix, where we like to have most of our extracurricular fun at Banner University in Phoenix. We honestly do have a wonderful overall team from top to bottom, exceptional surgeons who are not just known for their personalities, but skill as well. Imagine that. As of the past week, we have completed 131 heart transplants, and I think there's one going on right about now, so soon to be 132 since our commencement in early of 2020. And we are the #1 center in the world for total artificial heart heart implants. For those who have already saw me this past March down in the Bayou for AMSEC, I since got a haircut, so hopefully this presentation will seem completely different. But I did attempt to put a few new updates in there since then. Still nothing to disclose at this time. So some of the objectives that we'll be covering this afternoon will be a quick background and history of DCD and NRP, an overview of the equipment utilized to successfully perform NRP, the logistics of the whole thing, how we actually perform NRP, some of our experiences, including problems and complications that we've run into, what kind of staffing model we had to adopt at our account, and I'll end it with some discussion for the future of where this thing may be headed. So DCD, if you haven't heard by now, this stands for donation after cardiac death with planned withdrawal, sometimes referred to as controlled DCD. The donor does not always meet criteria of a DBD donor, donation after brain death, at that particular moment, but is on course for brain death such as coma, absent brainstem reflexes, and the inability to breathe without ventilatory support. So this is a part that could be a little morbid for some, but you obviously have to wait until the donor expires on their own. Declaration of death must be confirmed by a donor facility physician to avoid conflict of interest with the harvesting team, and the harvesting team is not allowed to touch the donor until 3 to 5 minutes after confirmed cardiopulmonary cessation by that donor facility physician within the US. I've come across a few articles from Italy that state they have a no-touch time of 20 minutes, pretty stark contrast from us here in the United States. The withdrawal of ventilatory support can occur in the OR, which is the best case scenario for ischemic time and transport of the donor. It can have an PACU pre-op, and sometimes in an ICU if it's near the operating room. Our team will typically wait 60 to 90 minutes, recently stretched to 2 hours a couple of weeks ago, for the donor to expire, depending on who's giving us the commands back at home base. But really, any time over 60 minutes is at a heightened risk for ischemia. During this time, the harvesting team is not allowed to be in the same room as the donor and relies on the staff from the Organ Procurement Organization, or OPO, as you'll hear it referred to as, to give updates on donor vitals and status. Some newer parameters to look at that have been popping up more in the literature would be the definition of functional warm ischemic time. We have previously started our warm ischemic clock as soon as the donor is extubated, but it may prove more beneficial to adopt thresholds for certain hemodynamics before you start your warm ischemic timer. For instance, for the systolic blood pressure to drop below 70 or even 50 millimeters of mercury, combined with or without an O2 saturation that's less than 70 to 75% before you start that warm ischemic timer. Which then leads us to NRP, which stands for normothermic regional perfusion. NRP is useful in DCD by providing warm oxygenated blood to the heart and or abdominal organs that allows for their reanimation while reducing myocardial injury, promoting energy storage, and maintaining homeostasis. It also allows the harvesting surgeons to assess each organ under direct visualization in situ. NRP is initiated once median sternotomy has been made and the head vessels are completely occluded first and foremost. Now that we've established what NRP is, now we can discuss the main two types being utilized now to my knowledge. We have thoracoabdominal NRP, which is the method that we deploy in hopes of procuring a heart. Central cannulation is the most common strategy that I've come across for thoracoabdominal NRP with the hard shell reservoir in order to empty out the heart and lungs further to aid recovery of the heart. Abdominal NRP is utilized in hopes of procuring abdominal organs, liver, kidneys, pancreas, etc., without any intention of procuring the heart. Typically, an intra-aortic balloon occluder is expanded above the celiac trunk, or more simply, a cross clamp to stop blood flow from reaching the brain or the heart. An even more simplified circuit can be utilized in this situation, such as a closed circuit without a hard shell reservoir, considering you do not need to empty out the heart. Although it may be easier to de-air if certain complications should arise with the utilization of a hard shell open reservoir. A little brief history on DCD. The first adult human-to-human transplant was Christian Barnard in 1967, was procured after cardiac and circulatory arrest. An NRP method was likely used, as one article stated that upon medical examiner's pronouncement of donor death, Barnard's assistants then rapidly opened the chest, initiated pump oxygenator support, cooled the heart to a low temperature, and excised it. As soon as the news spread about Barnard's DCD transplant, the United States quickly put in place criteria for what is classified as brain death, and DCD for hearts was not revisited for quite some time. The use of DCD and NRP was not seen again for adults until 2008 in the UK, and the US did not utilize DCD in adults until 2019, when Duke first transplanted a DCD heart from an organ care system. After we started our heart transplant program in 2020, we then successfully performed our first DCD with NRP approximately 2 years later. All right, now that we got the boring stuff out of the way, let's get down to business on the perfusion equipment that we utilize for NRP. Currently, we are using our trusty Medtronic BioConsole that I'm sure you all have lying around somewhere in a closet at your hospital, if not already in your normal rotation. We also have a special sprinter cart from a company called CoreSight that fits the Biomedicus perfectly with a small footprint. The small accessory table line tray ended up being a savior that we found in our pile of old holders and attachments, which allows us to push the circuit up to the operating table with a small sterile field holding our lines that the scrub can easily grab from the field. To achieve the normal thermic part of NRP, we use a micro temp LT heater by Cincinnati Sub-Zero. It's not the most efficient, but gets the job done and is very compact. We also bring our own iStat point of care machines so we can do our best to rely on ourselves and not the donor facility. With that being said, we obviously rely on the donor facility for oxygen to the circuit, which we have simplified and just use 100% O2 supply from the max port on the anesthesia machine. I understand that there is some literature out there stating the detrimental effects of hyperoxia, but contrary data can also be found. As of now, we haven't had any notable issues with tissue damage during NRP, especially tissue damage related to hyperoxia. We do our best to limit the amount of equipment that we need to bring as much as possible, and we deem that a mixer blender would be unnecessary and also leads to one more thing to worry about and another piece of equipment that could get damaged or fail after traveling. We've also held off on giving our surgeons a pump sucker for similar reasons of trying to keep the circuit as simplified as possible, but could be easily achieved by bringing along a separate cardiotomy with suction attached to it with a clamp on the outlet that could be released when you want to add shed blood to your CPB reservoir. Although the activated and angry shed blood from the field of a deceased donor may not do wonders for your blood pressure. Also, don't forget the small pieces like an oxygenator holder. I recently sent out one of my teammates on an NRP run, and I had an epiphany after she was already flying to her destination. I stole the oxy holder so we could have a dry setup for our new Essence pumps. This is where that perfusion mentality of making do in any situation comes into play. She was able to successfully tape her oxygenator to the reservoir holder without any issues, but I'll take the blame on this one. I set her up for failure. I wish I recorded our joyous FaceTime together. So here's a shot of our setup at a donor facility prior to donor withdrawal. Everything here ready for action. You can see the oxygen line coming off the left side of the circuit. That attaches to the anesthesia machine, just in the perfect spot to trip the surgeon. You know, they always love that kind of stuff. The sprinter cart is really ideal for this procedure, although the fifth leg coming off the side is a bit of a pain to deal with when you're attempting to stuff it into small cubbies of an airplane, but is also the location for the storage of an O2 tank that you need it. Here's a picture of our exposed backside, highlighting the small sterile field on the tray that contains our sterile AV loop and venous cannula that we'll discuss again later. This really does make things easy so you can focus on your circuit without having to hand the scrub your tubing, and everything can happen in one motion as you push up to the field. For disposables, we use the Medtronic tubing packs, infusion oxygenator reservoirs, as I'm sure you've already gathered from the previous pictures. We mostly bring 2 sets of everything other than tubing packs and oxy reservoirs due to the size of the containers. So we just hope and pray that they work properly out of the container and that nothing ever happens to them during transport. This is a list of some of the extra supplies that we bring along in a backpack that is always stocked and ready to go. We have a laminated checklist that lists each item as well as the equipment and main disposables that resides in the backpack that we are sure to double check before leaving our home hospital, but we may have to underline oxygenator holder for the next run. Our lovely surgical technologists have their own checklists and list of supplies that they are responsible for. Here we are again, hoping and praying that no one drops a cannula. They also have a list of supplies that they request from the donor facility, such as the sternal saw, as well as various sutures and other basic materials that any OR should have on hand. Here's my quick nausea-inducing video for practice circuit that we set up for training our perfusionists. This was before we started utilizing the table line tray for the AV loop, and did not hook up the heater at this time either. Now into the logistics. The harvest team, typically consisting of a surgeon, assistant, perfusionist, scrub tech, and procurement specialists, that all need to be transported from your home hospital to the airport or straight to the donor facility if it is local. If air travel is necessary, then you need someone to pick you up from the airport to successfully transport you to the donor facility. Sometimes they get lost along the way, it happens. Then if you actually procured a heart, it's time to hightail it in the reverse order. Most of the times we travel in 2 different vehicles. That allows one part of the team to either head straight to our home hospital as quick as possible without waiting on stragglers, or if out of town, those who are no longer a part of the actual procurement part can start loading up and head to the airport to pack and be ready for liftoff as soon as the heart arrives. We also do our best to arrive at the donor facility approximately 1 hour prior to planned withdrawal of the donor in order to set up the OR and set up and prime the NRP circuit. This is the typical suburban style vehicle that picks us up, each of us up from the hospital. But what you really want and pray that shows up is something like this bad boy, Mercedes Sprinter van, that has plenty of room for all your equipment without having to use separate vehicles or play Tetris with your equipment. You can even get the Sprinter cart to stand upright in the back. Sometimes it's just the little things. And the company that is contracted to transport us is very accommodating and helpful. They always have a cooler loaded with drinks, snacks, and will even order you takeout, typically on the flight, or drive to your home hospital. We've had from all the way from Fleming's to McDonald's and everything in between. Here's a shot of our Pelican flight case, keeping all of our precious hardware safe and sound, packed tightly with foam. Although on the way home, it doesn't always look this neat when you're rushing to tear down and pack up, because you either have a heart that's ready to roll or impatient team members ready to rush out because the donor failed to expire within the allotted time, and now everybody's just waiting on you. Here's a picture of all the perfusion-related equipment and disposables ready to be taken down to the ambulance bay. After all that fun, we've made it to the operating room. If the donor withdrawal was in the OR, the harvest team is waiting in the substerile area outside of the OR. with the surgeon and assistant already gowned and gloved. If the donor withdrawal was anywhere else, the harvest team usually waits in the in the OR for the donor to be brought in after they have been declared. Each hospital has their own protocols to where they want withdrawal to be in conjunction with the family's wishes. Sometimes they have even allowed us to prep, drape, and hand off table lines before withdrawal, which really streamlines the process. Once the donor has expired, the appropriate time has passed, and the donor is prepped and draped. Incision is made all the way to the sternum, and sternotomy is performed. Care is taken to quickly find the head vessels and clamp them off prior to cannulation, so there is no question of any possible donor awareness. Then a stab incision is made into the aorta, and an 18 French arterial cannula is inserted. Using a bulb syringe, the cannula is quickly de-aired, and the arterial line is connected. Another stab incision into the right atrium is performed in order to insert the 36 French single-stage venous cannula that is already connected to the venous line. During this hectic time, our current setup makes it easy to push up to the table in one motion, as I alluded to previously, and the edge of the tray of the sterile tubing towards the scrub tech without having to worry about pushing a separate table or opening a sterile pack to the scrub. Once the cannulas are in, it's time to crash on bypass and begin to resuscitate and reverse that black blood. With our more experienced NRP harvest team, we can be on bypass within 3 minutes after the approximate 3-minute no-touch time, even when the donor is coming from outside of the operating room. During this time, anesthesia from that donor facility, or maybe if you're able to con one of your anesthesia buddies from home to tag along with you, they attempt to reintubate the donor. Reintubation is key if you want to get off pump quickly, especially if they are turning down the heart, but we'll have more to come on this as well. Here's a quick shot of our scrub techs in action, prepping the lines and attaching the venous cannula to the venous line in preparation for the quick stab incision. For prime drugs, we use most of the basic drugs we use for any CPB case, except we add an extra amp of bicarb and an extra 20,000 units of heparin. Although the donor was given 30,000 units of heparin prior to withdrawal, I don't always trust how, when, where it was given. Also, a significant amount of time could have passed since it was administered. So it's always a good idea to CYA to make up for any previous shortcomings that may have occurred since going on pump. I know another hot topic of conversation has been the use of mannitol during CPB in terms of the degree of hyperosmolarity that can be created and its effects related to post-op delirium and kidney injury and function. Well, right off the bat, we can check off post-op delirium off the list in this situation. And so far, we haven't been notified of any kidney injuries post-implantation. All the abdominal surgeons have been happy with our results so far, which I'm sure is why this thing is really blowing up right now. But future studies are definitely warranted to see how such drugs may impact graft longevity, even after they are flushed during procurement. We still utilize the mannitol to try and mitigate those third spacing effects, considering the donor will be receiving a large bolus of crystalloid without any great means for displacing that crystalloid. More costly colloids could be used, or even PRVCs in the prime. But again, you have more questionable fluids that could be argued as detrimental, especially if you do not need them in terms of giving bank blood. In our experiences for thoracic NRP, the donor fails to expire within the allotted time more often than not. So I believe priming with PRVCs would be wasteful to our already depleted stores. On to the next controversy. Some may scoff at me for possible reperfusion injury, but we've had good luck going on with a high sweep gas and obvious 100% FiO2 from the anesthesia accessory port. That's why we also use the mannitol for the free oxygen radical scavenging. Even though my new hire likes to inform me about the article that states mannitol doesn't scavenge like we were told it does, but you know, there's always another article proving it does. So for blood flow, we target a typical cardiac index of 2.4. I've come across other NRP articles stating that they target 80% of a 2.4 cardiac index for thoracoabdominal NRP and 60% of a 2.4 cardiac index for abdominal NRP. Although I'll always lean toward the higher end, or at least keep up with my venous return. Once things have calmed down a little and the cannulas are secured, it's time to get an ACT as soon as you can. Once the venous blood color is looking better, it is a good time to grab a blood gas and see how well you guessed on your settings. I usually get a gas approximately 10 minutes after initiation if all is going well. The pump runs themselves usually aren't too long, and if they are, that usually means they're questioning the viability of the heart. If it is decided that the heart will be procured, you'll start to wean and transfuse as much of your volume as possible so you can tear down quickly once you've terminated, so you do not have to continue to transfuse once you're off. The surgeon likes you to give volume if needed, but also wants your butt out the door as soon as possible so they're not waiting on you to cross-clamp. One of those many times where you can never win. Here we are in the thick of things. Since February of 2022, we have been a part of 25 DCDs with planned withdrawal and NRP anticipation. 13 have failed to arrest during the allotted time, and 8 of the 12 have been successfully transplanted, which should be current data as of now. I've personally been a part of 10 of the 25 cases with 5 failures to expire, 5 expired cases, and 3 hearts actually procured. The joke was that we were always coming home empty-handed if I was involved. I guess I was kind of the opposite of the Grim Reaper. People just wanted to stay alive. The hearts that were turned down that I was a part of was due to probably being a little new to the game and attempting to procure anything that was offered to us, as well as not requesting enough diagnostic tests on some of the donors that we probably should have. In fairness to my knowledge, the donor hospital has to front the cost of all diagnostic tests performed on a donor, so there's typically some pushback on what tests they will actually perform. One donor was involved in an MVA with a no myocardial hematoma that we assessed after resuscitation that was deemed non-viable after reanimation. The other donor that was denied after reanimation was a younger male in his 30s that ended up having multiple surprising coronary lesions that no one was expecting at that age. We have since been stricter on who we will consider for DCD and push harder for more diagnostic tests before the deployment of the team. I'm sure by now there are other teams out there performing more NRP cases than us, especially with the increase in abdominal NRP, and I always enjoy conversing about how others run their programs and listening to their experiences. So hopefully this meme will stick in your guys' head when you're out there performing NRP, especially if this is your second time seeing it. So some of the complications that we've come across more than once are arterial line malfunction, cannula dislodgement, and the inability to re-intubate. Arterial line malfunction is one thing you can almost just assume is always going to happen, especially if the donor is being moved rapidly from a gurney to the operating table. It either dampens beyond use or anesthesia can't even find the transducer because it's likely underneath the donor. We got in the habit of transducing the central aortic pressure using the cardioplegic cannula once the arterial and venous cannulas are secured. Which brings me to my next favorite pastime, cannula dislodgement. As you can imagine, the situation is pretty hectic in the beginning after the donor expires, but the most important job the assist has at this point is to not let go of the cannulas. I've had 2 different instances now where a thoracic surgeon waiting to procure the lungs decided to assist our CT surgeon, who just assumed he could let go of the arterial cannula before it was secured. And then we had a CT fellow in a different situation who decided to let go of the arterial cannula before securement, which in the scramble to control the flailing line pulled out the venous cannula as well. Double the fun. Another annoying complication arises when anesthesia is unable to re-intubate. It may not seem like a big deal while on pump, but over time our encounters with the abdominal team started to notice how well their transplanted organs fare after NRP. So needless to say, if you can't re-intubate and the heart is not being procured for whatever reason, the abdominal team will kindly ask you to stay on pump for as long as it takes to procure their selected organs, which is now given rise to the boom in abdominal NRP, I assume. A complication that we are still dealing with today is obtaining and maintaining our CLIA license in order to perform iStats while out on an NRP run, as well as for iStat testing during mobile ECMOs as they were lumped together under the same license in our case. When we first started this program, our lab at the hospital basically refused to help or support us in any way because we were traveling outside of the hospital and could be performing tests in uncontrolled environments, as they like to tell us. So we are still currently in this struggle, although we have found an RN educator within our hospital that is willing to help manage the program. And we have an intensivist from our facility for our lab director. I have been acting as the technical consultant for the iStats and have been performing the competencies with my team in order to make sure they know how to properly perform point of care lab tests on the iStat and to keep up with proper documentation, which our RN educator is helping me with immensely. I also wanted to stress the importance of who is covered under the CLIA license. Just because a circulator may have credentials to perform iStat at your home hospital doesn't mean that they can run iStats at another facility or while in transit. With that in mind, we also keep our iStats for NRP and Mobi ECMOs completely separated from our home facilities OR iStats to avoid confusion, and we never dock them on the iStat docking stations in our home ORs. We were initially surveyed in 2022, and we have our follow-up survey tomorrow, so cross your fingers that Joint Commission doesn't bring down the hammer on us. So on to staffing. Let's start with the most appealing aspect that anybody on any team will love is another call position. Yeah, because we don't take enough call already. Obviously, another call position has to be created considering one perfusionist must be with the potential recipient of the organ, and the other perfusionist will be going along for the procurement. We treat the NRP person as a backup call position, so they rarely get called for actual emergencies on nights or weekends, and you typically get plenty of heads up before a potential DCD procurement. Performing an NRP is not very difficult under relaxed, controlled conditions compared to what we normally do in the OR, but for the most part, there are high intensity cases, especially in the beginning, and the surgeon needs to be able to rely on the perfusionist to be able to adapt to high pressure and unfamiliar situations. I tell my staff who are attempting to train for NRP that pumping the case is the easy part. It's making sure you're prepared for any scenario that can come along at any period. For instance, making sure you have all your equipment and disposables before leaving your hospital for starters. Also making sure you're capable of properly loading and handling all of the equipment into various vehicles and finagling that equipment into small aircraft without any snafus. Lastly, adapting to different environments and operating rooms that you may come across at other donor sites. On the topic of inexperience, it proves difficult to train and precept others during DCDs, considering seating is limited in vehicles, especially with air travel, and all weight and personnel must be accounted for each flight. Also, they seem to occur at times where the rest of the schedule is too busy to accommodate two people leaving on a flight, or it's after hours and the team member may have prior obligations. If they really want to train to be able to perform NRP, they have to be willing to sacrifice non-call days to go on a potential procurement. Considering that we are contracted to work at this hospital and are not paid hourly, we have some nice incentives built in for going out on procurement, especially with the risk of flying involved. Some of our staff members elect not to participate in NRP because of the fear of flying, but we have plenty of others who will gladly go instead, considering there's substantial pay incentive involved. With abdominal NRP taking off so rapidly over the past year, some new staffing models have been talked about and I'm sure are being deployed in some areas of the country with utilizing ECMO specialists to perform abdominal NRP. At first, it may sound great to reduce our workload and send someone else out on NRP procurement without having to change up our regular OR scheduled cases or add another call position. Although I worry about an ECMO specialist's technical skill set in this particular situation and environment, and I worry about giving away too many of our perfusion responsibilities with regards to the future of our profession. I honestly don't mean to degrade any ECMO specialists out there, especially those who may be watching now. And I know there are some spectacular specialists out there that could run circles around me in the ICU, but sometimes in the trenches of the operating room and an unfamiliar operating room at that, our specific training and extracorporeal circulation will prevail in adverse conditions. It's funny, the day after I was just putting together this portion of the slide, I came across a letter from the ABCP and their stance on this exact topic, which states, the emergent technologies of ex vivo organ procurement and NRP have enhanced the viability of donated organs, and the trajectory of these techniques appears to be robust. As the only medical professionals with the appropriate training, clinical experience, continuing education, and professional support necessary to reliably and optimally perform these critical procedures, The American Board of Cardiovascular Perfusion insists on utilizing CCPs for these procedures. It will definitely be a topic of debate and interesting to see what the future holds here. So with that being said, the final topic I'll touch on is about the future may hold for DCD NRP. One challenge that we would like to overcome for the future would be a way to better determine which DCD donors are more likely to expire within the allotted time frame. As stated previously, we had 12 out of 25 total DCD runs that failed to expire, which wasted a lot of time and resources, not to mention giving hollow hope to a potential transplant recipient. One of our surgeons is currently working with multiple neurologists in attempts to create a scoring protocol that could help guide the team's decision-making on which donors should expire the quickest. Artificial intelligence has also been discussed as another possible resource that could potentially aid in the selection of prime DCD donors. Although since my presentation in March, I still haven't seen much progress being made in this arena. We just had another potential 2 weeks ago that everyone swore was going to expire, but even after waiting 120 minutes, the donors still failed to expire. There were a couple of articles that stated donors that have the best chance of expiring before 60 minutes have an oxygenation index greater than 3 and an absence of brainstem reflexes such as cough, cornea, and extensor or motor reflex to pain. Femoral cannulation prior to withdrawal has also been brought up amongst our team as a way to expedite initiation of CPB and further decrease ischemic times, although I feel many ethical hurdles would have to be overcome considering the harvest team is not allowed to touch the donor prior to declaration of death, which I have since come across a few articles out of Italy describing these hybrid teams known as EISOR, extracorporeal interval support of organ retrieval, who are only there to perform cannulation and reanimation of donor organs and are not involved with the actual procurement process themselves. That allows them to sidestep that conflict of interest. Another article out of Italy that I came across, thanks to my buddy Harry from Cedars-Sinai in LA, who's always posting great content on LinkedIn, shows a modified mini circuit composed of a closed system with an LV vent wide into the venous line to aid in decompression of the heart during thoracoabdominal NRP. I'd be curious to see if this method in action and to see if it will truly decompress enough for the heart to fully recover in all circumstances. In Phoenix, we also utilize the Transmedics organ care system in certain situations, such as long distances. We recently completed our first OCS implant that was transported over 2,000 miles away. Even though there is some competition between NRP and OCS, I do believe they can coexist together and both have their own niche within DCDs. Collaboration could consist of the utilization of NRP for initial reanimation and direct visualization of organs without the risk of wasting costly OCS supplies before determination of a viable organ. Once the organ is deemed acceptable, it could then be transitioned to OCS for transport, especially over greater distances. This method could also decrease the time from donor circulation cessation to reanimation, considering we have observed some occurrences of lengthy time from harvest to OCS resuscitation that proved to be detrimental to previous viable tissue. I believe some average time from donor declaration to machine perfusion on OCS was approximately 40 minutes, compared to our time of approximately 3 minutes to restart blood flow from our NRP circuit. I have heard talk that NRP to OCS has already happened, and I would be curious to see if it begins to happen more often. At our facility, we have actually used OCS for a lot of our potential DCDs so that we can save our personnel, most notably our surgeons, as they have been preferential to the method of a heart just magically appearing in the OR versus them having to go get it. I believe we've had some burnout over time with how many failed DCDs that we've come across. Transmedics carries a hefty price compared to the cost of NRP, but sometimes the toll on personnel can become greater than financial costs. More opportunities to perform NRP for abdominal DCDs are now seemingly becoming more popular, as we have been previously discussing. Once the abdominal surgeons observe DCD organs that have been perfused and resuscitated with NRP techniques, there is no denying the positive impact it made on the harvested organs compared to only cold static storage. Another article out of Italy, surprise, surprise, these Italians are really pushing the boundaries, explains how they're using regional tissue oxygen saturation to trend and estimate adequacy of renal perfusion during ischemic times after withdrawal, as well as during reperfusion to determine viability of donor organs. So in conclusion, I'm hopeful the future will hold further acceptance of DCD NRP from all of our medical community and general society that will allow us to increase our efforts of expanding the donor pool that is currently nowhere near meeting the demands of our current population with organ failure. And thankfully, it seems to be heading in the right direction. So thank you, everyone.
Greg, thank you very much. What a fantastic presentation.
Problem.
Wet our whistle for this and really get us going. We're going to enter the question and answer period at this point. George, you wanna lead us off here?
Sure, Greg. First, congratulations on your program and a great overview of your program. I'd like to start off with some of the questions in the chat about staffing. Apparently, you only send a single person out on DCD runs, and so who helps you, with all the equipment, transport, and it's a lot of stuff for a single person to carry and move around.
Yeah. Yeah. Honestly, our surgeons, they'll even help out. I know we always joke like, oh, careful, smashing your fingers or doing this and that. And, they're younger guys and, they don't like to shy away from work or lifting heavy things. So they're actually a big help. And some of our procurement specialists that come along too. And honestly, all the team, I've even had pilots help us lift things into planes, and everybody's honestly really helpful, and which is great, because it doesn't, allows us to only be able to send one person, which is great for our team. And yeah, we're just thankful for everybody's help and all the help we can get during the whole process.
You brought up the American Board position statement on NRP, and thank you for doing that. That was very timely addition.
Yes, it was.
What's your thoughts on perfusionists only being able to do NRP, and how do you relate the skills necessary for NRP to traditional cardiopulmonary bypass?
Yeah, I definitely believe that CCP should be the ones participating in NRP. We have that specific skill set. It's like this is exactly what we went to school for. We're trained exactly of how to deal with these situations. And from a typical, it's different from a typical cardiopulmonary bypass case. But if you have a patient crashing coming into the OR, you're kind of in that similar situation where you're doing your best to crash on bypass as soon as possible. They're rolling in, they're throwing betadine, and you're crashing on pump trying to save somebody's life. Now you're only trying to save organs, but you're already, you already have experience in dealing with those situations. Where compared to somebody, I mean, people obviously crash on ECMO too, but in different situations, you're probably, not necessarily cracking the chest. I just feel, that perfusionists definitely have more experience in that regards, and will be able to, play it more cool in that situation and not let the just that hectic situation get the better of them, and do what's best to procure those organs.
Yeah, I think I certainly agree with you. I think all the potential calamities or problems that can occur during conventional cardiopulmonary bypass, you also see them during NRP.
Yes.
Cannula dislodgement that you brought up, right? That's a perfect example.
Yes.
And I think you need someone with that experience and skill set to deal with those problems.
Yes. And then with that being said, using a closed circuit, seems great as well. But then in those situation of a cannula dislodgement, and then you have massive air, now you have a whole new set of problems and time consuming process of trying to de-air. And then if you throw an ECMO specialist on top of that, I just think it's, even more a recipe for disaster.
Um, Jeff, I'd like to move over to laboratory testing, right? So it seems like most of your NRP experience to date has been thoracic for procurement of hearts. Is there interest in your facility from abdominal transplant surgeons? Our practice has been just the opposite. Where about 60% of our NRP is for abdominal only organ
Yeah.
procurement.
hmm Yeah. So I think, once we started our heart transplant program, we had been doing total artificial hearts for a while. And then, finally segued into heart transplants. And then we all, like I said, our guys are, they're pretty young, like doing new things and trying the new stuff. And so once we got that going, then we were pretty gung ho on starting NRP as soon as we could. And so I think we were a little ahead of the time of our abdominal surgeons, at least at that point. So what kind of sparked their interest, and I know, around the country, I don't know if it happened this way everywhere, but I know they were doing some abdominal stuff before thoracic. But so just at our facility, once we started it, then yeah, a lot of our abdominal guys and abdominal guys just, in the area, yeah, they started noticing how well their organs were doing versus when they were just doing a grab and go and throwing them on ice. They're like, hey, we got blood flow now. Like, this is awesome. They can kind of take their time a little more, and then their organs do great after reimplantation. So now that talk is, it's definitely more now. One of the abdominal guys, he did reach out to us, and at the time we weren't able to staff his requests. And now I think he's people are trying to start their own, specific NRP companies to, fulfill the void for a lot of these abdominal surgeons now. And he was recruited a few of our cardiac surgeons to even help him with the process of cannulating and all that. So yeah, like I said, we'll see what see what the future holds. But yeah, it's definitely catching on quicker and quicker here.
Greg, I have a question from Jordan here. I'd like you to elaborate on this question for me, if you will. Jordan wants to know, why do you need a heater cooler for already a cold cadaver donor? In my experience, the heart function returns to normal without one. And in this case, it might be one less thing to have to pack. Could you comment on that question?
Sure. Yeah, that's a good question. Honestly, I think we're kind of more, it's a little more for the ethical sides of things. Yeah, you're not going to get that cold where I don't think, um, heart function is going to suffer from it. It's more of we're trying to stay normal thermic, in the in the description of it, and do our best to just stay warm, and keeping up with that idea that the patient is dead, and we need to stay within those guidelines of a confirmed death, and no question of, well, they were cold, so now there's a lot of ethical and moral gray areas here that people will debate back and forth all day long. But as for now, within the laws that we are, with our no touch time, we're doing everything we can to respect the donors and their families and their wishes, and also at the end of the day, do our best to procure the best viable organs, to save the next patient. And so I know that was kind of a lengthy answer to a simple question, but and in some situations we honestly have gone without using it just because it was malfunctioning once we got there, and we just had to go on without it. There was no other option, and yeah, it was fine. So, but I would say it's kind of more on the technicality side of things versus actually needing it.
Yeah, I will add that we do not take a heater cooler on any of
Okay,
our
yeah.
NRP runs. We just
hmm
let the patient drift.
Yeah, yeah.
There's several questions in the chat regarding CLIA, laboratory, etc. Um,
Mhm.
I'd like to expand on that a little bit. Like you, we also use iStat. We also take um, a Piccolo machine, which does a whole liver function panel test with
Oh,
us
wow.
as well. Um, we went through the same questions when we started our program, and we came to the conclusion that technically we're doing laboratory testing at this point on a cadaver, not a patient. And
Hmm.
so, like you, we keep our iStats completely separate. So, separate supplies, separate
Yeah.
machines. We never dock them, etc. And so, it was the determination from our laboratory director that this was research and did
Yeah.
not follow under our CLIA license.
Yeah.
What's your thoughts on that?
Yeah. So, our surgeon, he mentioned the same things. Then I've heard other people that say, no, you still have to have a CLIA license for it. So I wonder, just since this whole thing is so new, we don't have a lot of the answers just yet. And hopefully, like I said, tomorrow we have our meeting with Joint Commission. So I'll, find out even more tomorrow. But, the other issue with my particular situation is that it got lumped with mobile ECMO. So now we're kind of hosed in that regard as just, you know, pulling off as just saying it was, it's only organ testing, the patient's dead. We're not doing actual patient testing. So I don't know if we kind of messed ourselves up in that regard with having Mobi ECMO lumped into it.
Yeah.
That could, that's probably one of our biggest issues with it. But our Mobi ECMO and the NRP was kind of similar times. So when our lab at the facility, was learning about everything, they wanted to wash their hands of it and kind of just left us high and dry, which is pretty annoying because we at least like some guidance or something of where to go with it. And but now I think we're in a better situation. We have people in place and people for kind of checks and balances and making sure we keep up with the licensing requirements and all that. And but yeah, we'll see what happens tomorrow.
Greg, in regards to hematocrit drop, Jordan wants to know how low will you let the hematocrit drop before dropping packed red blood cells?
Good question. We don't have an exact threshold. We like to stay around 24. It's usually just a discussion with the surgeon every time, and to see what they think, or to see what their thoughts are on taking to heart if in the first place, just to make sure you're not wasting any blood. But yeah, we do definitely make sure that the hematocrit is adequate, especially if it's going to be procured um, and taken to the recipient. Do you have a threshold, George?
We use 24 as well as our threshold. And we transfuse liberally. So we
Yeah, yeah.
routinely have a minimum of 6 units of packed red blood cells available to us for each
Hmm.
NRP case.
Sounds good. Yep.
Gentlemen, you both do NRP. Talk to me just a little bit. Robert wants to know as well. Talk to me about documentation during a run. Do you document flows, pressures, meds, gases? Do you have a standard document? Does it vary? What do you both do?
So it's funny. One of my pictures you could probably see when we were the one with the actual blood that we were on NRP was my paper chart there in the corner. So at our facility, we do still paper chart because at the banners here, we have multiple different contract groups going to banners in Phoenix between us, specialty care, and CCS. And they don't want to have separate charts from, even though we have our own electronic chart, CCS has their electronic chart. Banner doesn't want to see separate charts. So we all have to paper chart for them and then do our own chart for, our companies. So, so when we go on a DCD run, we just, paper chart like we normally would on a regular cardiopulmonary bypass case. And so, which is nice. So we're keeping up on, all the parameters that we would during a CPB case and a normal situation. And yeah, so we have records of all the runs we've been on with the full charts and all of that. But which I know we've been bringing up since this is so new, we do want to start looking at more quality parameters that we'll probably update in our database for, better tracking of these cases. Yeah, just looking at those quality indicators a little more closely.
George,
Yeah,
what do you guys do?
yeah, we keep a full record as well. We use the Spectrum system, and so we have Viper integrated into our transport monitor. So we have a full electronic perfusion record, which gets uploaded to our database and also creates a PDF file record for the organ procurement agency. As you know, American Board now recognizes NRP as a case credit. And part of that requirement, if you want to claim them as a case, is you have to maintain a record, just like you do for cardiopulmonary bypass.
So, yeah. It's
Are
great with
either one of you
technology
worried about,
nowadays.
I'm sorry, are you either one
Sorry.
of you worried about the bioethics of this procedure or the workarounds? I know that there's quite, and I know that's a loaded question. I'm sorry to kind of just throw it out there, but can you define a little bit of the differences between Europe and here? It seems that Europe, I'm assuming from what I'm hearing, is doing this a lot more a lot more than we are. And is there criteria difference? Talk to me a little bit about what you're hearing in the chat of the bioethics of those.
Well, I'll just start the conversation. Certainly, Europe has a lot more experience on this than the US does. The other thing you have to remember is different European countries have different laws and definitions of death, right? And so I think that also impacts some techniques that you may read about in countries like Italy and Spain that would be, I think, a challenge to maintain our legal definitions of death. And the legal definition of, DCD is that there's no blood flow to the brain, and that's why the isolation of the cerebral vessels is required. But I think there is as we do more and more ethical questions come up. We know of some hospitals who ethically objected to NRP and DCD donation that are now kind of softening those positions and allowing things like abdominal cannulation only NRP. So I think that's an evolving, but it does vary from hospital system to hospital system.
Greg, you want to add to that or?
Yeah, no, that was great. Yeah, it was just interesting to me, like you're saying, the differences. I know I put in the presentation, but even like Italy's no touch time of 20 minutes, I thought that was pretty crazy, crazy to see that. And the difference between here and yeah, I don't know if that's just on their side of, if it was an ethics committee, just to double make sure that they're not going to wake up or something. But yeah, it'll be interesting to see if those times start changing anywhere else that we might see.
One of the other things, we're kind of coming close to the top of the hour, but I kind of wanted comments from both of you. So one of the questions, how do you attain training for this? Let's say we've got a center that's looking to do it. I mean, what do you guys recommend for training?
I mean, first off, I guess practice circuits, and then you're gonna probably have to start out with a lot of your strongest team members, especially ones that have already been in those high intense situations. Just someone experienced with taking call and being in those hectic moments of crashing on bypass and stuff like that. Because if you're familiar with that, doing NRP, it's not much different. It's just like I said before, just kind of making sure you have all your equipment. That's kind of like the main stressor in the back of your brain as you're getting your stuff together. And that's, the importance of checklists, ever since perfusion school, it's, always the importance of checklists. And they really are a savior. They make you feel, more comfortable. It's such an easy thing. And, some people like to overlook it, but, I wouldn't. It's there for a reason, and it helps you out greatly. So to me, it's like, yeah, if you have that experience, you can do it. It's just making sure you're comfortable with all your supplies and your equipment, and you're ready to be confident once you get to a foreign OR.
Yeah, I think Greg hit it there. We are a two-person NRP team, mainly because of the intensity of our lab testing that we do. And so that allows us to pair an inexperienced person with an experienced perfusionist in NRP. So, but I think practicing ahead of time, but like Greg said, checklists are very helpful. And just being prepared that you're going to be in a foreign environment. You may be going to a hospital that has never seen cardiac surgery, never
Exactly.
seen a heart-lung machine, doesn't know anything about cardiopulmonary bypass. And so you really have to be prepared and bring everything that you need with you because you may not have any resources.
Exactly. Yeah, when we first started, I think before we brought an iStat, we were, making sure before we got to the donor facility, if, they had capabilities to run an iStat. And then you get there and the nurses scatter. They don't want anything to do with what you're doing. And so, yeah, it's definitely best to make sure that, you're only relying on yourself. You're not relying on the donor facility really for anything related to perfusion, because exactly what you said, it might be a center that's, has no idea what is going on. Yeah, always best to make sure you're to do everything on your own.
Yeah.
Well, everybody, we're at the top of the hour, and I just want to thank Greg for all of your presentation, and I think this topic has really got a lot of teeth to it. To be honest, I think that as we start doing this, as we proceed forward, I do believe that we're going to see this continuously come up as a possibility of what we're going to be offering. And it'll be interesting to see what the rest of the community does. And Greg, again, you've done a great job on the presentation. Really appreciate you doing that.
No
George, it's fantastic having you as a co-moderator. Here on the screen, I want you guys to see just our email addresses in case there's something you need to reach us for. Gentlemen, thank you very much. I want to thank everybody for attending. I want to apologize to everybody. We've got so many questions lit up in our question and answer section that we just couldn't even get to it. Maybe we need to revisit this in a second presentation. Again, thank you everybody for attending tonight. George, Greg, Maggie, really appreciate everybody. Have a great night.
Thank you.
Thank you.